Damas y caballeros, colegas, mi nombre es Ricardo Ceballos. Les damos la más cordial bienvenida al segundo Simposio Internacional en Desórdenes Vestibulares, esta Masterclass en Desórdenes Vestibulares y Oculomotores. Esperamos que así lo sea para ustedes. Nosotros anticipamos una gran experiencia con dos de los exponentes mundiales icónicos actualmente en el mundo del vértigo, desórdenes vestibulares y oculomotores. Como ya han visto, David C. y Michael Schrupp están con nosotros en yo diría, un banquete extraordinario, un pasadía completo de aprendizaje y que seguramente tendrá la finalidad de que tan pronto ustedes regresen a su consultorio y tengan a sus pacientes enfrente, puedan aplicar de modo inmediato los conocimientos adquiridos aquí. Es para mí un verdaderamente honor trabajar en el Centro Médico ABC, en el Centro Neurológico ABC. Particularmente ha sido un orgullo también pertenecer a esta institución que nos ha permitido desarrollar iniciativas académicas como esta en combinación sumamente fina, acertada, con laboratorios como Abbott, cuya visión de la educación médica continua, desde mi punto de vista, es algo atípica para lo que habitualmente se observa en la mayor parte de los laboratorios, en donde la preeminencia del anuncio de sus productos sobrepasa con mucho el fin último de este tipo de eventos, que es la educación de calidad, sin ninguna tendencia y sin ningún tipo de parcialidad. Entonces, la combinación entre la parte académica, Vestibular Project, que es la parte, digamos, el branch académico de la Clínica de Vértigo ABC, mi hospital, mi Centro Médico ABC y Abbott han dado muchos frutos que probablemente ustedes han seguido a lo largo de estos años. Eventos, simposia, masterclasses como esta, reuniones, etcétera. Entonces, es para mí un verdadero gusto el poder contribuir con ellos y ellos con nosotros para esta simbiosis, que sin esta simbiosis realmente eventos de esta calidad y magnitud no existirían en ninguna parte del mundo. Lo más importante es siempre la parte académica, el trasfondo científico y por fortuna creo que lo logramos, pero esa es una decisión y opinión final de ustedes. La Clínica de Vértigo ABC y de Vestibular Project realiza desde hace casi una década actividades educativas que sirven para mantener, desarrollar o aumentar los conocimientos, habilidades y el rendimiento profesional que utiliza un médico para proporcionar servicios de pacientes al público o a la profesión en el campo de los desórdenes vestibulares y oculomotores. Les damos la más cordial bienvenida también a las delegaciones de 10 países, a las delegaciones de Ecuador, Perú, Guatemala, El Salvador, Honduras, Costa Rica, Puerto Rico, República Dominicana, Nicaragua y a colegas de 23 estados de la República Mexicana. Perdonen ustedes si omití algún país, es una lista que me dieron al corte de la noche. Quisiéramos particularmente ofrecerles unas palabras de bienvenida por parte de las autoridades que han hecho posible este encuentro. En primer lugar, quisiera pedirle a la doctora Aurelio Méndez Domínguez, director de la práctica médica del Centro Neurológico ABC, unas palabras de bienvenida para ustedes. Aurelio, por favor.
Muchísimas gracias, estimado, queridísimo, apreciado, admirado Ricardo Ceballos. El Centro Médico ABC es una institución de asistencia médica privada sin fines de lucro que está cumpliendo 128 años. Este 12 de diciembre tendremos 128 años de edad. Hace 10 años se constituyó el Centro Neurológico. El Centro Neurológico está integrado por diversas líneas de servicio y el liderazgo lo lleva la línea de servicio de neurociencias que está a nuestra responsabilidad, junto con un equipo muy distinguido de muchos profesionales de las neurociencias. En esta línea de servicio ha surgido esta gran iniciativa, Vestibular Project, una iniciativa en donde el doctor Ricardo Ceballos lleva el liderazgo, lleva la responsabilidad y en donde ha hecho un maravilloso, estupendo, sorprendente papel. Este proyecto, nacido en México, desde el ingenio del doctor Ceballos, tiene una finalidad extraordinariamente de nobleza, que es el trabajo que ustedes realizan, el trabajo que todos realizamos en la práctica médica cotidiana, resulte en un bienestar de nuestros pacientes. Y esta es una labor extraordinariamente maravillosa. Si todo lo que aquí aprendemos y todo lo que aquí desarrollamos lo podemos aplicar en nuestros pacientes para que ellos vivan mejor, tengan mejor calidad de vida, ya se cumplió el objetivo que el doctor Ceballos en Vestibular Project ha delineado. De manera pues que esta experiencia fascinante deberá de tener ese fin. Este proyecto no sería posible si no fuera bajo el apoyo de nuestros colegas, aliados de la industria farmacéutica, que como ven ustedes el compromiso que tienen por la vida, como es el logo de Abbott, permite hacer posible el desarrollo de este tipo de eventos de altísima calidad. Quisiera no agobiarlos mayormente con mi discurso y decirles que ha valido mucho la pena el esfuerzo de dejar a sus familias, el dejar la agenda de trabajo y dedicar estas horas a obtener habilidades y conocimientos que redundarán en su práctica médica cotidiana. Doctor Ceballos, el resto del comité organizador, agradezco infinitamente la participación y a nombre de todos los miembros del Centro Neurológico, siga recibiendo nuestro apoyo para seguir en este tipo de proyectos tan fascinantes en la medicina. Muchas gracias a nuestros amigos también de Abbott. Gracias.
Por favor, le pido al doctor Jean-Pascal Beroux, es el director médico global del Sistema Nervioso Central de Abbott, quien ha hecho posible en gran parte el que tengamos esta reunión, este simposio. Unas palabras de bienvenida, please, Dr. Pascal.
Thank you very much, Dr. Ceballos. I have to apologize because I'm afraid I cannot speak Spanish, so I will have to make my talk in English. On behalf of Abbott, I would like to welcome you to this second ASVD meeting. My name is Dr. Jean-Pascal Beroux. I am the Global Medical Affairs Director for Neuroscience. I'm based in the headquarters of Basel Pharmaceutical, which is now located in Switzerland, in Basel. And with my team, we are actually responsible for the medical strategy of all the products in neurology, psychiatry, and pain. If I may, so just a few words, one sentence about Abbott. Abbott has actually a long history and a long heritage in neuroscience. And this is actually our everyday objective, to provide the medical community and, of course, afterwards, ultimately our patients with best-in-class products and healthcare solutions for various diseases such as depression, schizophrenia, epilepsy, migraine, Parkinson's disease, and of course, vestibular disorders. I have seen the program for today, and I must admit that I am very much impressed about the quality of the session that we will have today. I really do think, Mr. Chairman, that this is a perfect example of what a fruitful collaboration between a scientific society and a pharmaceutical company should be. And we at Abbott, and I personally in medical affairs, I would always welcome and support such initiatives. For this, and of course on behalf of all my colleagues being present here, I would like already to give you, Mr. Chairman, and all the speakers of today a big thank you for their participation. Having said that, as I don't want to be too long, I would like to conclude and simply to wish you all a very good day, a very good meeting, and very good scientific exchanges. Thank you for your attention.
Y finalmente quiero pedirle al doctor Alfonso Moguel Albertos, director médico de Abbott México, que aparte es un muy buen amigo y paisano, unas finales palabras de bienvenida para la audiencia. Gracias, Alfonso.
Muchas gracias, Ricardo. Buenos días a todos. Pues yo quiero ser breve porque ya somos 3 los que hemos estado aquí, pues dándoles la bienvenida en este muy relevante evento que consideramos será todo un éxito y muy provechoso para su consulta diaria. Pues yo solo quiero darles en nombre de México, en nombre de Abbott México, de todos mis compañeros, una muy cordial bienvenida a este banquete, como decía el doctor Ceballos, y decirles muy brevemente que el cambio es algo que vivimos todos los días en nuestro consultorio, que vivimos todos los días en todos los ámbitos de actividad que pudiéramos tener. El cambio que hemos observado, no solo sería un lugar común decir el cambio de la medicina a través de los años y en los años recientes con todos los avances que ahora se tienen, pero lejos de esto o adicionalmente a esto, el cambio de los pacientes que tenemos hoy, pacientes mucho más informados, pacientes que buscan soluciones integrales, pacientes que buscan una atención médica de calidad que ustedes le brindan día con día a sus pacientes. Y en este sentido, Abbott no ha sido ajeno a este cambio. Abbott se mantiene constantemente, dinámicamente cambiando en favor de la salud en nuestro país y en todo el mundo, por supuesto. Y este cambio básicamente se refiere a empezar a pensar un poco más en el paciente como un ser aislado, como una enfermedad nada más, a un paciente en una manera integral. De una manera integral porque sabemos que aquel paciente que hoy tiene vértigo o que ustedes pueden diagnosticar con vértigo, es un paciente que también puede estar deprimido, es un paciente que también puede ser hipertenso, diabético o puede tener migraña o alguna otra patología. Entonces, esta visión integral de un ser biopsicosocial que es el paciente, pues Abbott la ha tomado como un compromiso y estamos hoy comprometidos a pasar de un enfoque de productos a un enfoque de portafolio de soluciones integrales para nuestros pacientes. Este es el gran cambio que Abbott está ahora ejecutando y que ustedes verán en un muy cercano futuro a través del servicio que les damos en cada uno de sus consultorios y hospitales. Así pues, dentro del área de neurología, el doctor Jean-Pascal Verot ya comentó sobre las áreas de neurología que cubrimos y de igual manera lo tenemos en cardiología, en gastroenterología, en cada una de las especialidades para llevar este servicio integral al paciente. Pues quisiera pues ya no entretenerlos más para este gran evento, no omitiendo el darle mi muy cumplido agradecimiento en mi nombre y por supuesto en nombre de todo al doctor Ceballos al organizar este evento. El doctor Ceballos es una persona, pues además de un gran profesional y un gran científico, un excelente organizador porque es obsesivo con todo, le gusta que todo salga muy bien y lo hace de una manera fabulosa. Gracias al Centro Neurobiológico del ABC, gracias al doctor Aurelio Méndez y todo el equipo que organizó este gran evento. Quiero agradecer, por supuesto, a nuestros profesores, al doctor Michael Strupp, al doctor David C., al doctor Jorge Madrigal y, por supuesto, a mis compañeros en Abbott, que se han esforzado muchísimo y sería interminable mencionar a todos los que en Abbott hemos estado trabajando en esto, pero en especial a Fernando Avilés y a Alba Arrona, y por supuesto a todos mis compañeros que vienen de Chicago y de Basilea, el doctor Llanos, que está aquí también, el doctor Jean-Pierre Llanos. Y gracias a ustedes por este tiempo que están invirtiendo, diría yo, para la educación médica continua, que si hay algo que no cambia en Abbott es precisamente eso, el compromiso que tenemos con la salud, con la medicina, en cuanto a calidad de productos, servicio, atención y educación médica continua. Pues les agradezco mucho que estén acá y les doy un muy buen día. Gracias.
Bueno, sin más preámbulos, quiero ceder la palabra al doctor Michael Strupp, quien a nombre de él mismo y el doctor David C. van a dar una bienvenida respecto a su visita y las expectativas de esta jornada. No perdamos de vista que tanto el doctor Strupp como el doctor Z son en verdad científicos icónicos en el mundo de la neurotología. Mucho de lo que hacemos en nuestra práctica diaria proviene de ellos, de sus grupos, de sus investigaciones, y es un orgullo que estén hoy con nosotros. Muchas gracias. Please, Michelle.
Buenos días, señoras y señores y estimados colegas. Jean-Pascal Perrault, Ricardo, Abbott, muchas gracias por la invitación. So now I would like to move on with the second most important language, which I think is English. And I would really like to thank the organizers for inviting us, and David and myself, Miguel, would like to welcome you all to this masterclass. And I think we have designed a program which makes sense. So we first start with the basics, with the anatomy, so that you get an idea how the vestibular and the oculomotor systems work. Then we talk about the clinical examination. Subsequently, we are going to present the most frequent peripheral and central as well as functional vestibular disorders. And then a very important interactive part will follow. This is the clinical bedside examination. David and myself, we haven't done that before. For us, it will also be a new experience to run such a course with such a group of passionate listeners. For myself, by the way, it's the 15th visit in Latin America, the 10th visit in Mexico, and I do appreciate your most kind hospitality. I do appreciate how passionate you are in terms of learning something new about vertigo and dizziness, and to increase your knowledge and improve your skills in that field. And I think we have designed a nice show, and you should benefit from that. So, what is the problem that we are facing? Why did you all come here? Vertigo and dizziness are really frequent symptoms, and the lifetime prevalence lies about 30%. Second, vertigo and dizziness are easy to diagnose. It's almost boring in the majority of patients. You just have to listen to the patient, ask the right questions, do a bedside examinations. Sometimes you need a few machines, and then you can simply make a correct diagnosis in 90% of your patients, which is really impressive. And once you have made a correct diagnosis, you can also successfully treat your patients. And the first step of a successful treatment is to inform your patients about the disease he or she is suffering from. This is often neglected. So tell the patient why he or she feels dizzy. very important for the understanding, and then they can deal with their problems much better, and this improves their quality of life and their function. So that's all theories. How looks clinical practice? Clinical practice is completely different. I can say that at least for Germany, I don't know how it is in the US, but in Germany we have an inadequate but also an inordinate care. Too much is done. Too many examinations. MRI, EEG, long-term measurements of blood pressure, Doppler and duplex sonography. These are nice examinations, but they often do not contribute to the diagnosis. And unfortunately, often an incorrect treatment is given. And what you can see here are not the drugs that you should not give, but these are the drugs which were given to one single patient over a period of 6 months without knowing the diagnosis. And it's good to understand that the doctors often end up with antidepressants, because when a patient does not know what he or she is suffering from and he has ongoing problems, then it's a natural, I think, reaction to develop anxiety and depression. And this is something we should really avoid. In most patients we can do that. What is the problem that we really face? We can simply put that together by this simple list. Normally, we deal with just one patient. Second, there are 2 keys to make a correct diagnosis. We have just 3 types of vertigo. When you take the patient history, there are 4 basic questions. If you like to differentiate between peripheral and central vertigo, which is the first thing you should work on, there are 5 validated clinical signs. There are only 6 frequent peripheral vestibular disorders and 7 groups of patients, of drugs. And here you can see the different types of vertigo we are going to deal with today. These data are from our business unit, the German Center for Vertigo and Balance Disorders in Munich, on almost 20,000 patients. And you can see the data are quite robust. So number 1 is BPPV. Number 2 is phobic postural vertigo or dizziness, which is the most frequent cause of dizziness in younger adults. Then we have central vertigo due to ischemia, multiple sclerosis, neurodegenerative disorders. Vestibular migraine accounts for about 10% of all patients. Then there are 3 or 4 frequent peripheral vestibular disorders: Meniere's disease, vestibular neuritis, bilateral vestibulopathy, and vestibular paroxysmia. And rare disorders are perilymph fistula or other forms of psychogenic vertigo like panic attacks, agora or acrophobia. So with these 10 diagnoses, you cover 90% of the patients. So the problem is simple. And those diseases here indicated with the yellow outline boxes, they can be treated with drugs. So the majority of patients can be successfully treated with drugs. And what are the different types of drugs that you can give? You can simply summarize them by the 7 A's. Antiemetics for a pure symptomatic treatment. Anti-inflammatory drugs like corticosteroids for acute vestibular neuritis, for Cogan syndrome, but also for other inflammatory inner ear disorders. Anti-Meniere's drugs, in particular betahistine and gentamicin. Anti-migrainous drugs, beta blockers, topiramate or valproic acid. Antidepressants, SSRIs like fluvoxamine, in particular in males who suffer from phobic postural dizziness, they often need that. Anticonvulsants. This is not to treat vestibular epilepsy, which is very rare, but we have a lot of patients who have very short attacks of vertigo due to vestibular paroxysmia or paroxysmal brainstem attacks, and they can be treated with carbamazepine. A new therapeutic principle which we developed over the last 10 years is the use of aminopyridines, and a very recent new drug for vertigo, or ataxia, I'd better say, is acetyl-L-leucine. So that's the end of my introduction. I hope you got an idea what we are dealing with today. And now I would like to move over to the first lecture. Un momento. Okay, so I'm going to talk about the functional anatomy of the vestibular system, and complementary, David will talk about the functional anatomy of the oculomotor system. Why does it make sense to cover both areas? In every patient who suffers from vertigo and dizziness, it's essential not only to examine the vestibular system, but you also have always to examine the oculomotor system. Otherwise, you will never be able to differentiate peripheral from central vertigo, in particular in patients who show up with acute vertigo. And therefore, it's essential for the ENT doctors to improve their knowledge in the field of oculomotor disorders. And the same is true for the neurologists. They have to improve their knowledge in the field of the vestibular system. So, these are the anatomical structures we are dealing with. We have 3 semicircular canals and 2 otolith organs in each ear. The cochlea is mainly relevant in MDS disease. So now I'm going to try this seminar a little bit interactive. What is the function of the semicircular canals? Any suggestions? What do they sense? Angular acceleration, rotation, in all 3 planes. If a patient has an isolated problem of a semicircular canal, what does he or she complain of? What type of dizziness vertigo? Spinning around, rotatory vertigo. So this corresponds to the function. If a patient has an acute problem with a semicircular canal, what do you see during your clinical examination? And nice tap. How can you examine the function of the semicircular canals? Big-Hall pipe maneuver. You look for a BPPV, a dysfunction due to otoconia. But how do you check the function of horizontal semicircular canals? Which simple test? The head thrust or head impulse test, which is not as good as most of us assume. I'm going to show that later. So, there's a clear correlation. Semicircular canals sense angular acceleration. If there's a dysfunction, the patient complains of rotatory vertigo. You see a nystagmus, which corresponds to the canal. Ewald had already described that in 1890, so it's nothing new. And you can examine the function or the dysfunction either by the positioning maneuvers or by the head impulse. What about the otolith organs? What do they sense? Linear acceleration, and what you feel every second, if you're not in orbit, gravity. Okay, we are normally not aware of that. You become aware of that if you're in the orbit, there's something missing, and you feel terribly dizzy. Okay, what do patients complain of with an isolated dysfunction of the otolith organs? Dizziness, postural imbalance. Are there any situations when you see patients with an isolated dysfunction of the otolith organs? After head trauma, they may have otolith dizziness. Or after successful repositioning maneuvers in BPPV, because then there are relatively more otoconia on the utricle, and they also complain of dizziness. Now, a difficult question. What do you see during clinical examination if a patient has an isolated otolith dysfunction? Increased sway, you would imagine. Deviation of subjective visual vertical. We are not sure if this is a pure otolith problem. So anyway, it's hard to examine otolith organs during bedside examinations. Here we need some machines. I'm going to show them. Okay, so now we move on with the semicircular canals. And this is a very simple reflex, and only 3 neurons are involved. What does that mean for the latency? Long or short? The latency is very short of this basic reflex. The vestibular ocular reflex, the latency is only about 8 milliseconds. And this is important because when you're walking, you make high-frequency movements up to 25 hertz, and if you have a deficit of the vestibular ocular reflex, you feel dizzy, and what else do patients complain of if both labyrinths are not working at all? What do they complain of? Oscillopsia. Anybody in the audience who ever had oscillopsia, can you raise your hand? Who had oscillopsia? If not, you can do a very simple, David, of course. You can make a very simple experiment. Everybody, please, cover one eye, and now press with the tip of the index finger on the lower eyelid of the uncovered eye. Everybody, please. Lower eyelid, press on it. What do you see? The image is moving. So you have an apparent movement of the visual surrounding. This is oscillopsia. This is a frequent symptom of patients who have a deficit of the vestibular ocular reflex. And as I pointed out, only 3 neurons, very short latency, and you can also literally see how the vestibular ocular reflex works. So, everybody please, the following simple experiments. Hold your arms like that. Try to keep your head and your trunk stable, and just move your arm to the right and to the left with increasing frequency. Is the image sharp or blurred when you increase the frequency? Blurred. Okay, now do the opposite experiment. Keep the target stable and just turn the head to the right and to the left. How is it now? Stable. So in the first experiment, which type of eye movements did you perform? Smooth pursuit. David is going to talk about it. This is very nice to follow a target up to 100 degrees per second, but at higher angular velocities, the image becomes blurred. Which system did you use in the second experiment? Your vestibular ocular reflex. And you can literally see how it works. It stabilizes the image of the visual surrounding on the retina. And that's one of the major functions in addition to vestibulospinal reflexes, and this is achieved by the short latency due to 3 neurons only involved. And the major function of the vestibular ocular reflex, and this is also the basis of the head impulse test, is to keep the image of the visual surrounding stable on the retina during movements whatsoever in all 3 planes. So this is the basic function of the vestibular ocular reflex. How is this achieved? This is very simple biomechanics. Very simple at first glance. If you go into details, David, very complicated. But anyway, so it's due to the mass inertia of the endolymph within the semicircular canal. So if you turn your head in one direction, there's a relative movement of the endolymph into the opposite direction due to its mass inertia, and this leads to deviation of the cupula. And the dimensions of the semicircular canals are so small that the endolymph does not behave like water, but like oil. This means, due to adherence forces here, the endolymph moves only 4 micrometers, which is sufficient to stimulate or inhibit the vestibular hair cells. So in many textbooks, it's not properly depicted how the cupula is moving. The cupula is fixed to the ampulla, and it's moving in this or that way. It's not freely floating. If it be freely floating, the vestibular system wouldn't work at all. And now another important point. How is this mechanical signal transduced into an electrical signal? So this is basic neurophysiology. So on the top of the hair cells, you have these stereocilia, and on the top of the stereocilia, you have these tipplings. And the tipplings are directly, mechanically connected to ion channels. And these are unspecific ion channels. And now you can imagine if there is a movement into the direction of the kinocilium, there's a stretching of the tipplings, an opening of these ion channels, and an increase of the conductance. This leads to depolarization. But there's also movement possible in the opposite direction, and this leads to inhibition because the conductance of these ion channels decreases. So it's very important for your understanding. You have modulation in the on direction and the off direction due to these tipplings and adjacent ion channels. So now we talk about the head impulse test and the underlying physiology. So look here at this patient. Which side is not working properly, the right or the left one? The right one. And there's sometimes a confusion on which side the head impulse test is pathological. Very simple and very easy for you to remember. There's always excitation in the direction of the movement. This means when I turn my head to the right, there's an excitation of the right horizontal canal. This is also true for vertical canals. If I move my head downward, there's an excitation of both anterior canals, which lead to eye movements upward. Very simple to remember. And if you have this knowledge, you can easily interpret your head impulse test. In other words, if the head is quickly turned to the right and the eyes move with the head to the right, then the right horizontal canal does not work properly. Well, we have two labyrinths, as you see here, one on the left and one on the right side. As I told before, there's a modulation possible in two directions. Excitation, when I turn the head to the right, and in parallel, there's an inhibition of the contralateral labyrinth. Why is that not sufficient to generate compensatory eye movements? And this already had also been described by Ewald in 1892, because there's an asymmetry of the vestibular response. Two things we have to know. We have a resting discharge when there's no movements. If you move the head into the direction of the canal, there's an increase of the impulse frequency up to 500 hertz. The resting discharge rate is about 100 hertz. So if you move the head in the opposite direction, there's a decrease of the impulse frequency, but the difference, the maximum difference, can only be 100 hertz. And that's the physiological basic for this on-off direction asymmetry. Plus 400 excitation, but only 100 hertz inhibition. And this explains why we have this asymmetry. So one labyrinth is not enough, you need both. Then we have another finding, which is very special for the vestibular system. And this is a spontaneous nystagmus. So you can examine that with the regular Frenzel's glasses or these new M glasses. If you have an acute hearing loss, an acute hemiparesis, nothing else happens. But why do you develop a spontaneous nystagmus if you have a vestibular problem? What's the physiological background? Any ideas on that? What is so special about the vestibular system? The vestibular nerve, the labyrinth, I mentioned that before. It's the resting discharge rate. The resting discharge rate is about 100 hertz. So if you're sitting now here, your labyrinth is working with such a frequency. This is a little bit annoying, therefore I'm stopping. So that's the resting discharge rate of each of your axons. And you have 18,000 fibers on each side, So this will end up with 1.8 million action potentials per second when you're sitting here without moving your head. And now imagine that one labyrinth isn't working anymore. Then you have an active labyrinth on the healthy side. This generates 1.8 million action potentials per second. And this drives the eyes in the opposite direction. So this is like turning the head toward the healthy side. And therefore, the nystagmus also beats toward the healthy side. That's the reason why. So the driving force, the vestibular imbalance, tone imbalance, drives the eyes in the opposite direction, and then you get a spontaneous nystagmus, which is centrally compensated. So after 2-3 weeks, it's gone. What remains is the vestibular deficit, which can be detected by the head impulse test. Now, we move on with the macroscopic anatomy of the semicircular canals. Why is it important to have some basic knowledge about the macroscopic anatomy? Why do you need to know that the anterior and in particular posterior canal is deviated 45 degrees from the frontal plane? Any ideas? Why is it important? When do you need that in your clinical practice? We talk about functional anatomy. You need it every day, because when you examine a patient, and every patient should be examined by the positioning maneuvers, you have to turn the patient's head 45 degrees into the opposite direction. And the physiological or the anatomical background is that the posterior canals are tilted 45 degrees from the frontal plane. So if I'm going to examine my right posterior canal, I have to turn my head 45 degrees to the left to specifically examine the right posterior canal. You also need some knowledge about the horizontal canals. This is important if you do the calorics. The head has to be elevated by 30 degrees so that the horizontal canal is vertical. The same is true if you do proper examination for patients in whom you assume horizontal canal BPPV. The head should be tilted by 30 degrees upward. And if you would like to specifically examine the horizontal canal during your head impulse test, the head should be tilted 30 degrees downward. And this is the line between the porus acousticus externus and the angle of the eyes. So this line is exactly parallel to the horizontal canal. So head 30 degrees downward, then you specifically examine the horizontal canal. So now we move over to the otolith organs. As we already pointed out, the otolith organs detect linear acceleration and gravity. And this is achieved by the otoconia, which lie on top of the hair cells. The specific weight of the otoconia is 2.7 grams per cubic centimeter. And here again, the basic principle is the mass inertia, not of the endolum, but of the otoconia. So if the head is moved in one direction, there's a relative movement of the otoconia in the opposite direction, which either leads to excitation or inhibition of the vestibular hair cells, of the utricle and the saccule. The same is true if you tilt your head, the otoconia move downward. Short comment and something for you so that you can easily memorize it. What about the orientation of the utricle and the saccule? You all know the US dollar sign, and the sacculus is also oriented in the same direction, and the utricle is horizontal. So that's for you to remember. What is the basic function? The utricle, if the head is upright, senses movements to the right and to the left, forward and backward. And when the head is upright, the saccule detects gravity and forward and backward translations. Well, this video is from David. There are some tests which have been proposed to examine the utricle.
Now some head heaves. Okay. Head heaves. Look right at the tip there. Mm-hmm.
David, which side is the pathological?
Right at it. These are head heaves. Look right at that tip. Focus right in on it. Mm-hmm. some head heaves.
David,
Heaves. Look right at the tip there.
what do you suggest? It's hard to decide. So theoretically, this is a very elegant test, but in clinical practice, it could not be proven to be really efficient. So there's another test which requires some recordings, and this is the ocular counterroll. So you need machines like that, and we published something on that, so we can also measure the function of the utricle. But nowadays, the methods of art are vestibular evoked myogenic potentials. And there are two types of vestibular evoked myogenic potentials to test the function of the otolith organs. So for the utricle, we have the ocular vestibular evoked myogenic potentials. You can make a stimulation here with this mini shaker and do a recording from the contralateral inferior oblique muscle. I'll explain that later in more detail. For the saccule, you can make an acoustic stimulation and you record a vestibulocholic reflex inhibition from the ipsilateral sternocleidomastoid muscle. So once again here, for the utricle, stimulation by the mini shaker, recording from the contralateral inferior oblique muscle, while the subject has to look 30 degrees upward. Then you get an N10, P15 amplitude. For the saccule, stimulation by most often sounds, recording from the ipsilateral sternocleidomastoid of this inhibitory response P13 and N23. And here you can see how such a recording can be done. Now we start with the ocular vestibular evoked myogenic potentials. Two of my colleagues. You hear the sound of the mini shaker, and then it's stimulated. Patient has to look 30 degrees upward, and you record from the contralateral inferior oblique muscle. So this is a quite simple method, and it can be easily applied by everybody who's familiar with evoked potentials. When do you see pathological findings? As I said, the ocular vestibular evoked myogenic potentials measure the function of the utricle. So if you have a patient with a vestibular neuritis, then you see pathological ovals. And that can be easily explained. The majority of patients with vestibular neuritis have a superior vestibular nerve affection. And since the superior vestibular nerve innervates the utricle, you get pathological ovals. You can measure the function of the saccule by the cervical vestibular evoked myogenic potentials. You do an acoustic stimulation, and you record from the ipsilateral sternocleidomastoid muscle. So this is a little bit more difficult, but nowadays it's well established in many labs. This is important to diagnose inferior vestibular neuritis, and if you have a patient with a neurectomy, you don't get a response. So to summarize this up, the utricle function can be measured by the ovum, and in superior vestibular neuritis, you see typically reduced or absent ovums. The saccular function can be measured by the cervical band, which are typically reduced or absent in inferior vestibular neuritis, which is, however, very rare. Long story, short question. Do we really need the vans? David, can you live without them? Can you live without the vans? Me too. So it's a nice technique. For some labs, for some centers, it makes sense, but for clinical practice, it's not necessary that you make this investment. Later on, I recommend a different investment. So, now we talk again a little bit about macroscopic anatomy. In Latin it's called os pedrosum. What does it mean? Petrus, pedrosum. What's the meaning of that? It's a Latin word. Stone. Why do you call the temporal bone, why is the temporal bone called temporal bone? Because here the gray hair first develops. So you can estimate the age of persons by having a look at the temporal bone. This had also been familiar to the old Romans. So that's the name temporal bone. But the same bone is also called os pedrosum, stone bone. Why has this bone to be so hard? Because there should be no transduction of pressure to this pressure-sensitive system in the inner ear. So we have only two areas of access, the round and the oval window, and everything else is protected. Now listen to this patient here and try to make the diagnosis, which is related to the os pedrosum.
What complaints brought you to us today?
When I press on my ear, I have a slight attack of dizziness, or when I vigorously chew something.
Is it the left or the right ear?
The left.
Okay, what do you diagnose? Very simple. Takes 5 seconds. Perilymphistular. So most often patients spontaneously report their major complaints. Just listen to them, and then you can make a correct diagnosis. 5 seconds. And that's a typical example. But nevertheless, patients go from doctor to doctor to doctor. We had one patient who could hear his eye movements in his left ear. He spent 6 weeks in psychiatry. That's a true story. That's not long enough. Well, he had the same disease. This disease can be easily diagnosed. For instance, if you press against the closed nostrils, then you can induce a nystagmus. And a very sensitive technique, described first and recommended by David Z, is an examination with your ophthalmoscope. So this is a very sensitive test, also to detect nystagmus with a velocity of 0.5 to 1 degrees per second. In other words, if you examine the eyes with your ophthalmoscope and there is no nystagmus, there is no nystagmus. So this is a very sensitive technique. Cover one eye, examine the other eye. 1978, David C. Am I right? And to further support this diagnosis of a perilymphistular, you can also use the Pulitzer balloon.
Or 110 dB. 2,000 hertz, 110 dB in the left ear.
What is that?
Let's do that.
Tullio phenomenon. Some patients report that. So the very first patient, we saw him there, who was misdiagnosed as a hypomobile stapes, was the first patient with a superior canal dehiscence syndrome. He was a musician. He was playing the tuba, and at 440 hertz, he got dizzy. So, this is a frequent phenomenon, Tullio, named after this Italian physiologist, Pietro Tullio. You see him here with a rabbit changing the pressure in the rabbit's ear. So, in those days, before the Second World War, most of the scientific papers had been published in German, as you can see. Okay, so the diagnosis, first described by Lloyd Miner, David C., and John Carey from Johns Hopkins University, is superior canal dehiscence syndrome. Here you see a bone section with a dehiscent canal. Here you see an intraoperative finding, and the principle is very simple. When you have superior canal dehiscence syndrome, you end up with a third mobile window, and this leads to pathological transduction of pressure to the labyrinth and to the cochlea. Therefore, these patients have pressure-induced attacks of vertigo, oscillopsia. They can also have autophonia, hearing your eye movements, and they're often not diagnosed. It can occur after simple head trauma, and it's quite frequent, but rarely diagnosed. Finally, how do you treat these patients? first thing is explain the patient what he or she is suffering from and avoid changes of pressure. You can occlude the canal, and sometimes you can also resurface the canal, but the current method of art is occlusion of the canal plugging. So, I've approached the end of this lecture on the functional anatomy of the vestibular system. I'd like to briefly summarize the major findings. First, we have 3 semicircular canals which sense angular rotation. If their function is impaired, patients have rotatory vertigo. You see a nice tachmus which corresponds to the canal. You can test the function of the canal by the head and pulse. Otolith organs, utricle and sexual, they detect linear acceleration and gravity. Patients complain of postural imbalance, dizziness, increased sway. You may have a deviation of the subjective visual vertical, and you can measure the function by the O and the C number. Cochlea, you're more familiar with than me. Thank you very much for your attention.